Good afternoon. Thank you very much, sir, for your kind introduction. And I'm going to discuss with you about common gynecological problems. Actually, common gynecological problems we cannot discuss within half an hour. As females are quite common, it's a majority of in Sri Lankan population are female, their problems are also quite common. Therefore, I would rather happy to tell or I would discuss common menstrual problems with you. An outline of this lecture will be the brief account about abnormal uterine bleeding, and thereafter few case scenarios. We'll discuss what we come across every day in general practice. It's basically very simple kind of discussion we are going to do in next 10-20 minutes. So abnormal uterine bleeding. The earlier we used the terminology dysfunction uterine or DUB, dysfunction uterine bleeding. But nowadays we don't use that terminology because instead of that, there was a kind of a structure was given to find out abnormal uterine bleeding. There was a kind of discussion had in 2009 in Cape Town, and International Federation of Gynecology and Obstetrician, we call FIGO, given the structure for classification for abnormal uterine bleeding. And it is defined as bleeding from the uterine corpus that is abnormal. The abnormality may be in the volume. The volume may be higher than the usual, or maybe regularity or timing of occurrence. It should persist majority of the months during last 6 months. That's what we call abnormal uterine bleeding. But if we talk about that, the previous picture is more favor of chronic or persistent abnormal uterine bleeding. But if you talk about is there maybe a acute abnormal uterine bleeding? Yes. An episode of heavy bleeding, clinically significant and sufficient quantity to require immediate intervention to prevent further blood loss. Acute abnormal uterine bleeding may present in context of existing chronic abnormal uterine bleeding or might occur as an abrupt manner. But what is the reason? What are the causes for abnormal uterine bleeding? This acronym, PALM and COIN. It was given by FIGO, and the first part, the PALM, is representing the structural causes for abnormal uterine bleeding, and the other half, the COIN, represents the functional causes or non-structural causes for abnormal uterine bleeding. And structural causes, if we consider, first, the P stands for polyp. The endometrial polyp may be the reason for abnormal or persistent uterine bleeding. The next one, adenomyosis. As our Dr. Hemantha Pereira said, the adenomyosis is a condition. He has given kind of a brief introduction about adenomyosis. That may be the cause. L for leiomyoma. Generally we know it as fibroids. Usually fibroids do not cause any abnormal uterine bleeding unless it's located near to the lining of the endometrium. In FIGO classification, intracavity fibroids, submucosal fibroids, or we call category 0, category 1, category 2, category 3, which affect the contour of the inner lining of the womb, which can create abnormal uterine bleeding. And don't forget, another structural cause for abnormal uterine bleeding is malignancy. Those are the structural causes for abnormal uterine bleeding. Then we move to the other side, the functional causes or non-structural causes for abnormal uterine bleeding. C represent coagulopathy. This may be acquired or inherited type of bleeding disorder. And ovulation dysfunction, as we all know, if someone is not ovulating, there is no secondary phase of the menstrual cycle. Then only unenforced estrogen would act over the endometrium, which create proliferation and thickening of the endometrium, and in single point, the residua basalis cannot supply blood to the uppermost layer, which lead to necrosis and bleeding. That particular bleeding lasts longer and usually it is heavier. That is the reason why ovulation dysfunction create abnormal uterine bleeding. According to WHO classification, there are main three types of ovulatory dysfunction. The class 1 is the hypothalamic causes, we call hypogonadotrophic anovulation. The type 2 represent the normogonadotrophic anovulation. Type 3 represent hypergonadotrophic anovulation, that is because of ovarian failure. The E represent endometrial, and that is maybe endometrial pathology, the atrophic endometrium, endometritis, infection of the endometrium can create abnormal uterine bleeding. The I represent iatrogenic, and for us, if we cannot find out any cause, the FIGO hasn't given justification for us as well, the poor doctors, that is for not yet classified. If you cannot put any other reason to find out what is the reason for this abnormal uterine bleeding, that is just not yet classified. Yes, we'll discuss few cases. I would rather happy to get some kind of input from you as well. And this is case number 1. This is regarding puberty. Usually these kind of patients do not come to visit specialist. And for example, the mother carries her 7-year-old girl. As she got menstruation, there's a small stain, just a stain in the underpant. Mother wanted to know whether she attained puberty or not. I think the doctors who are doing general practice come across this kind of scenario. Then what would be the solution? Go behind the screen and put it into the chat GPT or put and check whether the child has attained to puberty or not. I don't think it is possible. But in this case, it's a critical case in mother's point of view, for a cultural background, cultural rituals and things. She thinks that sustaining is menstruation, but it is not as clear as pure blood. So it is a big problem for the mother. On the other hand, you are going to destroy childhood of the child. If you label it as menstruation, the mother will put that pressure over the child, and child will be rejected from the rest of the children, and she will be having different lifestyle thereafter as an adult. Therefore, you need to be very careful to give a proper answer for this question. The puberty, does it occur in a single night? No. Though we take menstruation as a the end results of puberty, is a sequence of events which happen over the period of time. There are physical changes and there are psychological changes. Forget about psychological changes. We won't be able to assess all those things in busy private practice. But physical changes you can assess. It starts with breast development and followed by growth spurt and pubic and axillary hair development, and last, as an end result, there will be menstruation. That is the one the society take as puberty. If the patient is not having secondary sexual characteristics, confidently you can tell, no, this is not the menarche. You can forget about that. You can reassure the mother. It is quite important to give proper instruction to mother, and if it is necessary, you can seek some medical advisors from your senior colleague as well. But if a child presents with bleeding or a stain in their underpant, you cannot just take it lightly. You need to pay attention over that, and you need to have a proper examination to find out What is the reason for that? It may be an accident, it may be some kind of physiological, or it may be some kind of sexual intervention or something like that. We'll move to the second one. A 13-year-old girl presents with irregular menstrual cycles 1 year after menarche. No excessive bleeding or pain, no hirsutism, acne or weight changes. This is also a kind of quiet presentation in day-to-day practice. When immediately after the menarche, it is quite normal to have irregular cycles. Period of amenorrhea may be 3 months, maybe 6 months, even sometimes maybe 1 year. But here, you need to look after two people. Again, the mother is the one who is panicked, and she needs some kind of answer. She wanted her child to have periods quite regularly immediately after menarche. But she cannot remember her past as a kind of, immediately after menarche, the way she got menstruation. But what is the reason for that? The main reason is immature hypothalamo-pituitary axis. Just after menarche, the hypothalamo-pituitary axis, the combination of the connection is not well established. Therefore, it will take some time to establish this pathway correctly. The second reason for abnormal or kind of prolonged cycles is anovulation. As I said earlier, because of unopposed estrogen, the lack of ovulation, there is no progesterone in her circulation. Therefore, hyperestrogenism will create overthickening of the endometrium and heavy bleeding, prolonged bleeding than the usual. The next thing is because of the sudden change of environment, psychological impact, and the social pressure, the child is having a bit of stress and other contributing factor. Again, it can contribute hypothalamo-pituitary ovarian function and which create abnormal uterine bleeding. But what is the treatment? Like, if I tell you, in our labor wards, there's a medicine, it is being used for every purpose. You know what is the medicine? That is syntocinon. Whatever the problem happened, lack of progress, delayed secondary stage, fetal distress, even doctor wants to go for a party, we use oxytocin. The same medicine, there's a kind of very important medicine what we use in day-to-day practice in upper general practice, that is northestrone. That is the medicine if somebody comes with any kind of menstrual problem, it may be cervical cancer, we use northestrone as the treatment of choice. COCP or combined oral contraceptive pills or progesterone containing drugs are widely used in Sri Lanka. But there are some controversies regarding using this medication in small children. Progesterone can inhibit, stop duct proliferation of the breast of that particular child. It can create the breast development, and at that particular moment, once you start progesterone, the child is happy, mother is happy, because the menstruation or the bleeding stops the next day. But the problem, once you stop progesterone, child starts to bleed. Rather than that, if it affects the proliferation of breast development, it may not be a problem of that particular time. But when the child is grown up, she pay attention over the shape and structures, then it becomes psychological problems for that particular child as well. But these kind of occasions, what can we do? That's the next step. The reassurance is quite important. Spend a couple of minutes with the patient and discuss with them and explain what is going on. And if you want to stop bleeding, you can use tranexamic and mefenamic acid rather than giving hormonal treatment which create the things more worsen. Right. We'll discuss about case number 3. A 19-year-old university student complains of infrequent periods, facial acne, and hirsutism over the past year. She has gained 8 kilograms in the last 2 years, and her BMI is 28 kilograms per square meter. The diagnosis is pretty obvious. Everybody knows the diagnosis, that is polycystic ovarian disease. But to diagnose polycystic ovarian disease, do we need all these features? Actually, no. There are different phenotypes of polycystic ovarian disease. Phenotype A is typical triad exist, where you get all three main criteria: hyperandrogenism, maybe clinical or biochemical, ovulation dysfunction, and polycystic ovaries. But phenotype B, it is non-PCOS, PCOS. It's a bit funny, isn't it? It's non-PCOS, non-polycystic ovaries with polycystic ovarian syndrome. Involves hyperandrogenism and ovulatory dysfunction, but without presence of polycystic ovaries in ultrasound. The ultrasound scan does no polycystic ovaries, but yet person is having polycystic ovarian syndrome. The phenotype C, the ovulatory PCOS, the characterized by hyperandrogenism and polycystic ovaries, but with regular periods. When you see the lady, she is obese, the BMI may be 35, 40, facial layer, acne, acanthosis, and everything is there, but the lady is getting regular periods. Yes, she is ovulating. That's a different kind of phenotype. And phenotype D, it's non-hyperandrogenic PCOS. Involves ovulation, ovulatory dysfunction, and polycystic ovaries, but there's no features of hyperandrogenism. These are the different phenotypes of polycystic ovarian disease, but you don't need to have all three triads to diagnose PCOS. The treatment, that is, you cannot address all the concerns at once. You need to find out what is the most important or the burning issue for that particular patient and give kind of tailor-made solution for that particular patient. The subfertility, fertility treatment, weight reduction, the insulin-sensitive agents likewise, and regularize the period. The COCP can be used, but anti-androgenic COCP, don't give Mithuri to each and every person because it contains androgenic fraction of kind of progestogen. Therefore, it creates things further complicated. If you give kind of COCP, give the progesterone which contain anti-androgen ciprotron acetate or kind of drospirenone containing COCP. I cannot tell some names, but if you go through those things, you will be able to find the newer kind of COCP. Excessive hair growth, the relevant treatment, acne, relevant treatment, but remember, the cornerstone of treating this patient of weight reduction and lifestyle modification. You need to pursue them to adhere with healthier lifestyle with exercises and weight reduction. The case scenario 4, a 39-year-old lady, mother of 2 children, present with heavy regular menstrual bleeding with 6 months period of time. Her hemoglobin is 9.8 gram per deciliter and she is not on any contraceptives. And this is kind of common complaint what we get in day-to-day practice. And here we need to apply and keep your mind the palm and coin theory and try to find out what is the reason. It's a structural cause or it may be a kind of non-structural cause. It's better to spend a bit time with the patient and get a good history, clinical examination. If necessary, you can refer patient for investigation, get ultrasound scan done, make sure everything is in order. And the treatment, again, if patient needs kind of contraception, you can give oral contraceptive pills with the newer version. It will regularize the period, definitely will reduce the amount of bleeding with regularizing the period. On the other hand, you can use mefenamic acid and tranexamic acid. Sometimes some people think giving mefenamic acid patient is not having pains, is not kind of logical. But these two drugs together synergistically reduce the blood loss up to 50%. And you can use, if patient is not having contraindication, you can use both together, which will be quite helpful. And this is the last one, no need to worry, and it's going to be finished soon. And the case number 5, the 47 years old lady present with irregular heavy bleeding. She feels some kind of vasomotor symptoms as well. This is kind of, again, common problem, but we get the middle-aged lady who is heading towards to the menopause. And it is not usually as menarche, it's menopause also kind of gradual onset one, is we call reaching menopause. It happens at the age of 45 years, and initially a lady experiences some kind of frequent periods followed by kind of infrequent periods, the lengthening of her periods. After that, it will stop roughly around at the age of 52 or 51 years plus 4 months. That is the average age the Sri Lankan woman get menopause. But here, usually happen the anovulatory cycles. It means there's no ovulation. There are no eggs in ovaries to kind of ovulate. Therefore, again, the lady is experiencing anovulatory cycles. The period of amenorrhea followed by heavy bleeding, clots, and most of the time pains as well. If you, in this situation, the one thing you need to remember, it is quite important. 1/4 of endometrial cancer occur in menstruating women. Therefore, if you think this bleeding is abnormal, if your scan says something different in the endometrium, it is better to go for endometrial sampling. Please refer the patient for necessary treatment. If not, if you think this is a kind of mere hormone, kind of just hormonal imbalance, you can start the treatment like notestosterone. If you give notestosterone, give it for 21 days. There's a progesterone support. It's 21 days, 5 milligrams daily dose would be enough. Notestosterone is a drug which creates lots of side effects, breast tenderness, fluid retention, mood swings, and all those kind of things. Giving notestosterone 4 or 5 days, for 7 days is not going to be effective. Once you stop the bleeding, patient will stop the treatment, patient will start bleeding again. Therefore, if you give it for longer period of time and keep a space of 7 days and repeat it another 21 days, likewise give 4 or 5 cycles, it would help her to regularize her periods and give a luteal support, and at the same time, progesteronic support. At the same time, unopposed estrogen, if create some kind of endometrial hyperplasia or something like that, it will help to revert the condition as well. That is it, I think, the treatment which I discussed earlier. Yes, this is the end of the discussion. I think if you have any question, you can direct it. At the same time, I would rather, I want to express my sincere thanks to Anuradhapura Clinical Society for inviting me for this particular lecture in their most important event of their clinical calendar. Thank you very much, President and the Council. Special thanks goes to Professor Kumara Disanayaka as well. Thank you.